Welcome to the final Experts in Conversation of this series. My name is Charlotte Teunissen. I'm professor in neurochemistry in Amsterdam UMC in the Netherlands. And I'm together here with my colleague Suzanne Schindler.
I'm Suzanne Schindler, and I'm a dementia specialist and the leader of the Fluid Biomarker Core at Washington University in St. Louis, Missouri in the USA.
We have a nice CTED conference here. And there are different themes that we can discuss. So first of all, screening in clinical trials, especially for prevention clinical trials.
Yes.
Was there something in particular that you've seen at CTED that really was interesting for you?
So a major problem with clinical trials generally is that we have under-enrolled minority groups, particularly Black and Hispanic individuals. And one problem with screening for these is that Black and Hispanic individuals traditionally have not been excited about doing lumbar punctures and amyloid PET scans. But now that we have these good blood tests, we think that we may be able to increase our representation. So there was a study led by Doris Molina Henry, where she screened many individuals, thousands of people with blood tests. And what was interesting is that she found that Black and Hispanic individuals actually had a lower rate of amyloid positivity. And that was surprising because we generally see a higher rate of cognitive impairment in those groups, but it does appear they have a lower rate of amyloid positivity, at least in that population that was screened. But because she used blood to do this, it was a relatively lower expense to be able to screen those individuals. And then you can do what's called oversampling, where you include more of the Black and Hispanic individuals in your eventual population. And when they were sent on to have confirmatory testing with amyloid PET, the blood test seemed to work well. So the people that were positive by the blood test were also positive with the amyloid PET scan. So it seemed like the blood test was working similarly in all groups. So that was helpful. But overall, what this means is that by using blood tests, that it's likely that we'll be able to increase the representativeness of our cohorts. And that's really great news.
Yeah, I completely agree. And I first thought perhaps the cutoff of the blood test is not good, but due to this confirmation by PET, I think it's the right answer. But still, it's quite puzzling that of the initial screen population wherein there was a higher presentation also of the underrepresented groups, that after the blood test it was a lower number. So we're losing people there, and yes. I think we need to understand why. I found it also very interesting to see that across time, that first they didn't have the blood test and they had, I think, about 70% screen failure rate. And then as soon as they introduced the plasma test, then they observed only, it went down to 30% screening failure. So I think it's really showing the added value of the blood test for such trials.
Yes, I completely agree. So these type of prevention trials were very expensive and took a long time to enroll if you just use amyloid PET scan, which is what they did in the past. But now with these blood tests, you can screen people pretty quickly and then find the people that are likely to be positive, and that really increases the speed, the efficiency, reduces the costs. So that's really wonderful news.
Yeah, I think so too. Completely agree. And now let's go to the timely diagnosis and the use of the biomarkers. There were presentations about the real-world use also, or perhaps not yet real-world prognostic, but there are a couple of such studies now being started. But there was also an interesting study about the use of the blood test in primary care settings, and depends on your healthcare system whether that is applicable. But I found it very striking that those blood tests in the primary care setting had a very good concordance with the CSF and PET confirmation. with the CSF and PET results. So I think the blood tests do not only function well in specialty clinics, but perhaps also in primary care settings.
I agree. And one point that I think is important is that primary care patients tend to have a higher rate of medical comorbidities. And there's been concern that the blood tests may not work as well in individuals with a higher rate of comorbidities, but the blood tests are working well in that population despite all those comorbidities. So that's very reassuring.
Yeah. Now, and I think going to details, I think the blood test or some of the blood tests, or depending on which proteins you are measuring, there is an effect of kidney disease and of BMI. But luckily, it seems that you can correct for that by taking a ratio. And I think it doesn't really matter what kind of ratio, but any ratio will probably correct for those inter-individual variations. I think that's also very good news.
Yes, absolutely. So it appears that that ratio really helps to improve the consistency of the results across individuals, regardless of their medical comorbidities. Of course, we still need to be careful for people who have really significant health issues, really poor kidney function, for example. But overall, it looks pretty promising for most patients.
But at the same time, I don't think we can really implement the blood test in primary care yet, because it's just one study that needs replication. I think it was also in a quite selected setting, because in the Netherlands, the primary care physicians wouldn't perform a CT scan, for example. And I think also coming back to the theme of diversity, I think that's also an aspect that we need to factor in, and that was this population was quite selected. And if we now see that there is a lower rate of amyloid positivity in the underrepresented groups, I think that's something we really need to pay attention to. And I think we need to learn more about the effects of other comorbidities that we have not anticipated yet and whether we can correct it also by simply using a ratio, or that we need to factor in more. That remains to be seen, of course.
Well, the good news is that there are many studies underway now, both in the US with, for example, the ADAC study, the HABS-HD study, as well as in Europe with the AD-RIDDLE study, where we're going to be looking at the effects of comorbidities. And some of these studies are also looking at use of blood tests in primary care. So I think we're going to be getting the answers to some of these questions fairly soon.
Yes, I expect so. But we should not only focus on the primary care. I think it's also important, or there's a big benefit of replacing lumbar puncture and PET analysis in the secondary care. And that will also reduce healthcare costs. So I think there is already a lot to gain closer to home.
I absolutely agree. And in my current clinical practice, I'm looking forward to when blood tests will be reimbursed, which they aren't right now. There's actually 6 tests that I can order right now in the United States. But the way that I typically use them is if people are clearly positive or clearly negative, I don't really feel the need to do a second test, as long as they're a highly accurate test. But if they're in the middle, if they're borderline, that's where we do the confirmatory testing.
Yeah, so now there is a lot of focus on P217, but other analytes can also add to that. Do you use that also in your clinical practice, like add information of GFAP, A-beta42, or also neurofilament light?
So currently in our clinic, we use a test called Procivity-AD2, which includes percent p-tau217 and A-beta42 to 40. And it's put into an algorithm, and out pops the amyloid probability score 2, which is a scaled value, model value from 0 to 100, which makes it pretty easy to interpret. So that's what we're using. We're not using GFAP or NFL routinely. We can order those. I typically don't, but if I had a patient who I was trying to differentiate between Alzheimer's disease and, for example, frontotemporal dementia, where NFL is much higher, then I would consider ordering NFL.
Yes, and that's also how we use it in our clinical practice. For frontotemporal dementia, we use neurofilament light a lot, and I think it's good to have multi-markers in our clinical practice, at least.
Yeah, I agree. And with time, we'll get more and more biomarkers that we can use and hopefully differentiate Alzheimer's disease from FTD from other disorders.
So there's another interesting presentation here at CTAD where they studied the effects of covariates on the outcomes. It was a post hoc study in the lecanemab data, but they made a score, a progression score, predicted progression score, which they factored in the data analysis. And it was quite striking how that reduced the variation up to 20% reduction and even 50% reduction for some of the outcome measures. And I found it interesting that the FDA is open to that. If you have covariates with proven relation with the disease, that you can include it in your data analysis.
I saw that study as well, and I thought that that was very clever, and it should be able to help us reduce the size of studies and increase their power. So that seemed like a very valuable approach.
Yeah, I completely agree. So indeed, also the reduction in the sample size that you need for your study was also very an important result. So that will also reduce the cost of the study, yet you will still have the same kind of valuable and trustworthy results.
The talk that I found most informative to me as a clinician who's currently giving anti-amyloid treatments was showing that if you change the titration of donanemab, that you could markedly decrease the risk of ARIA by 50%. And so that's the kind of information that we can take back to our clinic and really improve the safety. I'd like to start instituting that now. I don't see any really drawbacks to doing that. So that was incredibly informative and could help patient safety.
Yes, I completely agree. I found it very striking, also the differences. So the ARIA rates, I think it reduced to 13% only. So yeah, hopefully we can reduce it further, but the safety is the most important issue
Yes.
in this type of drugs. Suzanne, did you see the presentation about appropriate use recommendations for donanemab?
Yes, overall, the recommendations are very similar to the recommendations for lecanemab. So that overall makes sense. They're very similar in terms of the drugs. And I think, generally having consistent guidelines is helpful. One thing is that the recommendations are pretty conservative, but I think that they are really trying to emphasize safety right now. And they did leave room for clinicians to have judgment about specific cases.
Oh, that's very important. So it's also touches upon autonomy and also the discussion with the patients. And the titration is not yet in there.
No.
Yeah, so
I
think
think it will be added.
Yeah, that needs to be added. And in what respect do you think they are conservative?
So, for example, they recommend not treating individuals, excluding them who are on blood thinners. And there's actually relatively limited data suggesting that the treatments have serious adverse consequences in people with blood thinners. There's a theoretical risk, but in general, the risk of macular hemorrhage on these treatments is pretty low. So that's why I say they're trying to be cautious and just avoid some outcomes that would be pretty rare, but obviously would be serious outcomes.
Oh yeah, no, that's very important.
Yes.
Yeah. Can you talk to the eligibility of inclusion in the treatments?
So generally, when we've looked at the percentage of patients who come into our memory clinics who would be eligible for anti-amyloid treatments, it's actually pretty low. So a study that was presented here estimated about 10%. In our clinic, we're treating about 7% of our patients with anti-amyloid treatments. So sometimes people have the perception that we're just treating everybody that comes into our clinic, but it's actually a highly selected population. And that's for a number of reasons. One is that many patients that come into the clinic they don't have Alzheimer's disease, and they have other neurological disorders or conditions that are affecting their cognition. Another issue is sometimes they're too late. they're at a later stage when they're not eligible for these treatments, or else they have medical comorbidities that would prevent them from being eligible, or in some cases, they just don't want to do the treatments. So overall, the percent receiving the treatments is relatively low.
No, that's also good for people that are worried that it's flooding the healthcare systems. That's not too big, and we can gain some very useful experience with these numbers.
Absolutely.
So, Suzanne, can you summarize what were your main takeaways of CTED?
What I found most exciting was that a slower titration upward of these anti-amyloid treatments may significantly decrease the risk of ARIA. That's extremely important information for us and could immediately result in changes in our patient management. And then other takeaways are that plasma p-tau217 is performing very well in many, many studies across the world. And that it appears that blood tests generally may be extremely helpful in recruiting participants for clinical trials and may speed up this process and reduce costs, which is really wonderful because it means that we'll get to effective treatments more quickly.
Thank you. Yeah, for me also, the most striking results were those of the HEAD study, where we learn more of the use of the blood test for screening, and also how it can inform us also or help recruit underrepresented groups, and also help us inform on what's happening with people and also their comorbidities. Thank you very much, Suzanne. It was nice talking to you about
Nice
these
talking
topics.
to you.
And also thank you to you for watching this. Please complete the evaluation form to give us feedback and questions on the content so far and what would you like to see covered in the future. Thank you very much.